I'm Dr. Kavitha. I'm one of the pediatric endocrinologists here at Rainbow. And I'm just going to introduce all the three people who were part of this pediatric app. And it's the trainees, you, who need to use that app and let us know what the feedback is. I'm sure it will be very helpful. So I'm going to do a bit of introduction, but this is going to be short and sweet. My guru, Dr. William Lamb, but he's called as Bill, very favorably called as Bill. So Dr. Lamb trained as a general physician, so he's a general medicine consultant, and then he developed a special interest in pediatrics. So then he went back and did pediatrics. From there he developed his interest into pediatric diabetology. So you can see from there he's reached there, and then he became a specialist pediatric diabetologist. But the key thing, he maintained his general and neonatal skills, and that's where I could relate myself to him, and I've not left my pediatric and neonatal skills. I continue doing my pediatric clinics as well. And one of the key things he taught me was that you need to be very well aware, whatever part of pediatrics you are, about your nutrition aspects of the children. So he also spent 5 years working for UK with Medical Research Council as a nutritional scientist, which opened his eyes to importance of nutrition in every facet of medicine, leave alone pediatrics. And so I have learned my nutrition things from him. So I had to do about 30 or 40 hours of nutrition before managing my pediatric diabetic patients in UK through my training. So I had to spend 30 hours with our dietitians, and I'm very thankful to him. Dr. Lamb was involved in the development of NICE guidelines for diabetes in children and young people, and that's where the BSPD is based on. Trained in UK, I tend to follow BSPD, and that's what most of my trainees know as well. And that has been adapted from that, and he always sits on the review of the guidelines. So here he is. He's here to launch the app because he wanted to do the app for n number of years for the pediatric DKA, but that didn't materialize. But finally, we got to do it. And he's very happy, and he's here because he believes the app has come out very well. And the key thing he told was that this app has to be a free app. So it's not commercial at all. And Dr. Satish Deopujari, who is the pediatric intensivist, about whom I'll be talking in a minute, he has facilitated to give it as free. So there'll be no money for downloading that app whatsoever, and you're going to use it. Thank you. And my colleague, Dr. Leenatha Reddy, who is one of my colleague pediatric endocrinologists, is also here. And since my return to India, she's always held my hand. She's in the audiences. In a minute, I'll introduce her to you all. So the next one I'm going to talk about is Dr. Satish Deopujari. I call him Dr. D because I find it very difficult to either say Dr. Satish or Dr. Deopujari. So basically, he doesn't need any introduction, I was told. Most of the pediatricians here will know about him, and a lot of them who are sitting here. So I'm not going to say much about him. The only word I'm going to say about him is he's a senior pediatric intensivist from Nagpur, and wherever you go, you will either meet somebody who's trained, whenever you get into a pediatric world, you'll meet a pediatric intensivist who's trained by him, or somebody who's been trained by his trainee. So that good he is. So I'm glad that I was given this opportunity because he was the technical part of the pediatric diabetes app, and I'm just giving the knowledge along with Dr. Lamb as the algorithms, but all the technical bit is by him. I'm very proud to have him here. Thank you. And the last and the most important person for today, Dr. Vivek. So he is a pediatric intensivist. He's trained and associated with Dr. Deopujari or Dr. D from Nagpur. And the main important thing is he's the technical brain behind the app. So I have no knowledge about these apps, but my husband is an IT consultant, having worked for UK for the 25 years. So the way he dealt with the app evaluation, it is phenomenal. So any issue comes, you just tell him and he'll say 24 hours and then it just gets done. So he's too good with that. And the complete app is in such a short time, about 4 months he got it done. So, and the main thing I want to say is he's very quiet, down to earth, and he's a gentle person. And his work has to be appreciated, I would say. Thank you. Right, so next thing I thought was, instead of Dr. Lamb delivering lecture, because that's what he said, he doesn't want to deliver a talk or a lecture. So I collated questions from across the people who are here or who are not here, and I've given the questions so that there's no duplication. I made them. So there are about 10 questions which is going to answer, and there are about 5 to 6 rapid firing questions. So that will give you a flavor of what is pediatric diabetes or pediatric diabetic ketoacidosis management. And if there is anything outside that you would like to ask, please feel free to ask him. And I think you've looked at the title. It said a conversation with of pediatric diabetes with a living fossil, and he'll let you know why he wanted that living fossil in that title.
Good afternoon, and thank you all for turning up. I have to say it's a great privilege to be here today, and I feel very humbled. I have met so many who've done great things. I feel very insignificant compared to some of these people I've met. So why a living fossil? When I started looking after, when I started medicine, and diabetes in particular, there was no blood sugar machines. All the insulin was just Act Rapid and Insulatard. Everything was drawn up in glass syringes with a needle that you used until it was too blunt to get in your skin. So I learned to manage diabetes, and we did quite well without any of the fancy, sophisticated stuff that's around today. And if you like, I'm a link to those past days. And what you learn to manage somebody when you haven't got those tools actually helps you when you do have the tools. And that's the position I'm in now. And I've had the privilege of seeing an explosion in the way that diabetes is being managed. So now in the UK, the standard treatment now for children is to have continuous glucose monitoring, and if they wish it, to have a pump linked with an algorithm. So more and more children are having the opportunity to have their lives with diabetes made much better. Anyway, that's enough to say. And do you want me just to read the questions out?
Yes. And just one before you start the questions. And I just wanted to acknowledge our academic head, Dr. Wilson. He's always been supportive of me for the academics which I've gone through, and I'm very thankful to him. And Dr. Nitin, who is a cardiologist, but he's been trained with Dr. Satish Deopujari, and is here to just show his respect to his senior consultant here. And Dr. Naveen, who is a pulmonologist, pediatric pulmonologist, and he's a good friend. He's always been there as a supportive person to me, and I'm very thankful. And Dr. Pratima, who is one of my friends who are here. I acknowledge each and every one. And Dr. Inder Sen Reddy, he's an adult endocrinologist, but he's always been supporting Nova 8, through which you can deliver free insulin to the children who are who cannot buy them because of the cost restraints, and he's here as well. And thank you one and all for being here. And then Dr. Kishore, one of my pediatric endocrinology colleagues, is also here, and I'm thankful to every one of you.
Okay, so the first question is, how relevant are international DKA guidelines to the average Indian cohort, given that children who present in DKA are very sick, and the second part, have low muscle mass? Okay, so believe it or not, the international guidelines are almost identical to what I was using 40 years ago. So they really haven't changed much. What has changed is the evidence base by which those guidelines are now delivered. But really, not much has changed at all. And it's relevant to children all over the world. One of the problems we're finding in the UK at the moment is post-COVID, there's been an explosion in the incidence of type 1 diabetes. And we're seeing double the numbers. And because of that, increasing numbers are presenting in DKA. So it's not just India. Over 50% of the children new diagnosis are in DKA, some of them very, very ill. So I don't think that's different, but I suspect that within India, a greater proportion of children will present in DKA and be ill. What's very different is the nutritional status of children. In the UK, they are well nourished from a very early age. In fact, too well nourished, most of them. Whereas in India, I think you will have a very different cohort. My experience in Africa is anything to go by, they will be largely underweight and will have reduced muscle mass. Why does this matter? Can you think of why having reduced muscle mass might make it difficult to manage DKA here?
Below?
Yes, because reduced muscle mass means there's less total body potassium, but we'll maybe come on to that later. But otherwise, I don't think there's much of a difference. What are the minimum investigations that are required to safely manage a child or young person who presents in DKA? I think it would be ideal to be able to measure pH and blood sugar, and also potassium. If you can measure those three things, then I think it's safe to manage a child with diabetes. But to be honest, if you are careful in your management, those things are just a guide. What matters is the care with which you follow a child with diabetes and DKA. What I mean by that is if you follow the fluid management, if you give the right amount of insulin, if you do it in a safe way, the child will get better. When people don't follow guidelines, or when things are going wrong, that's when the measurements become more important. Third question, where or which setting a child in diabetes and DKA should be managed? Should it be in a ward or a PICU? With no offence at all to my PICU colleagues, they come at sick children through the lungs and the heart. And that's where their focus is. When you're dealing with DKA, your focus is on the metabolism that's wrong, the physiology. And so I think, personally, it's where you have somebody with knowledge of diabetes. That's where they should be managed. If you've got a PICU consultant who knows about diabetes, then that's fine. But in all the years that I've looked after children with DKA, I have never admitted a child to PICU. In the UK, PICU is very expensive. And if you say to a PICU consultant, I've got a sick child here, they will say, no, they're not sick enough for me. They don't like to expend the money. So we've always managed children on the wards. And it's absolutely fine to do so. I think in a PICU, because you're so used to intervention, I think it sometimes could be more dangerous. And there's the next question, which is linked, which is who should manage DKA in children? Should it be a pediatric intensivist or a diabetologist endocrinologist? Subsequently says, in the US, it's led by pediatric intensivists. In the UK, it's led by pediatric diabetologists. And I think that tells you the answer, really. It's whoever has the expertise. You should know what you're doing. But the reality for children who present with DKA is that they are often looked after, I should imagine, within India, in a small rural hospital, where there isn't a pediatric intensivist, where it's a busy hospital, it's late at night, there are a dozen children who need to be seen. And the problem is, how do you get that expertise? Which is where this app comes in. And this is why I was so excited to be here today, because this app allows somebody without experience the expertise to be able to manage a child safely. So I don't think there's anything special. Personally, I think a diabetologist should manage it because it's a disorder of metabolism, and the treatment is with insulin and fluids. And unless the child is very, very ill, I don't think there's any advantage about being in an intensive care. Can I ask, have those explanations so far been okay, or would you like more detail? It's okay so far. Another question here is your thoughts on the ideal fluids in the management of pediatric DKA. One of the things I've learned over the years is that the more complicated you make things, the more mistakes are made, the more dangerous it is. So to me, the ideal fluids are the ones that are available, ready, prepared, there for you to use. So normal saline and dextrose saline, because they're there and ready. And if you have it with added potassium, that's even better, because every time you add something else to a fluid, you add risk and danger, and this is where things go wrong. So the ideal fluid is what's available, what's safe, and what doesn't need to be added to. And also, what's cheap. You don't want fancy fluids because you use a lot of them. So to me, normal saline with potassium, normal saline with dextrose and potassium. If you've got those three things available, then that's all you need. Question 6, what is the correct dose of insulin? And the comment is, please explain the physiological basis to justify the low dose insulin usage in the BSPED guidelines. Okay, so a question for you to answer. What is the normal starting dose of insulin? If you were giving, saying the total daily dose of insulin that you would give to a child newly diagnosed, what would be the normal dose of insulin that you'd start with? per kilogram per day. 0.7 units per kilogram per day, isn't it? That's the standard dose. So, simple calculation, 0.05 units per kilogram per hour. What is the total daily dose of insulin from that? 1.2 units per kilogram. Okay, so the low dose usage of the BSPD is double the daily dose of insulin that you would normally be giving a child. Is that a physiological dose or a pharmacological dose? So 1.2 units per kilogram is for the BSPED one. So if you look at the ISPAD guidelines where they say 0.1 units per kilogram, how much is that? 2.5 units per kilogram per day. I mean, that's a super pharmacological dose. That's a huge dose of insulin to give. Okay, so when you give insulin to a child with DKA, what are you trying to do? What is the purpose of that insulin? It's to stop the production of ketones, right? That's what you're doing. You give insulin and you stop any more ketones being made. And then the body will clear the ketones naturally. Insulin doesn't clear ketones. You clear them through the kidneys, you clear them through your lungs, you clear them through metabolism and cell usage. So what you're doing when you give insulin is you want to stop ketones being produced. What is the physiological dose of insulin that stops ketone production? Well, in a normal child, it'll be about half a unit per kilogram per day. So what's the point of giving them 5 times the physiological dose? Giving them 5 times the dose does not stop the ketones any more effectively than the natural dose, and it doesn't clear ketones any more efficiently. What it will do, what giving a pharmacological dose of insulin will do, and I know there's a nephrologist in the room, what do you use insulin for in nephrology? For hyperkalemia. What does insulin do? It drops potassium. It does it really well. That's why the nephrologists use it when they're really worried about somebody's hyperkalemia. So giving a pharmacological dose of insulin to somebody whose total body potassium is already massively depleted, what is it going to do to their potassium? It's going to drop it even faster. Now, when a child presents in DKA, they are so sick. They've got sick tissues, they're acidotic, so their circulating blood potassium, which of course is only a tiny amount of the potassium in the body, could be high or even higher than normal. But if you were a nephrologist and you wanted to drop their blood sugar, what would you do? You'd give them insulin. And so we'll probably come on to the, oh yes, the next question is I'm scared of potassium. Okay, so all I'm saying is that the whole point of giving insulin at the beginning of the treatment of DKA is to stop the further production of ketones. After that, then you will start to drop blood sugars as well as you start to mobilize glucose into the tissues. But the primary purpose is to stop more ketones being produced. And therefore, a physiological dose of insulin would do it, and a pharmacological dose of insulin would do it, and the BSPED guidelines is a pharmacological dose. And the other thing that pharmacological doses of insulin do, what do they do to your blood sugar levels? Yeah. And so if you give a pharmacological dose of insulin, you're much more likely to cause hypoglycemia. So I think I've always used the lower dose of insulin, and I have to say that I have never had to treat somebody for hypokalemia in all the years that I've managed. And hypoglycemia during the initial stages of management, again, is something I've not experienced. So I would say that I think I can justify the low dose of the BSPED. Next question. I am scared to add potassium to fluids in DKA management, even though the child is passing urine. Inadvertently, the majority of children in DKA end up having hypokalemia. Then we're needing to give potassium corrections and central lines. Even when we add potassium, we start with 10 millimoles per 500 ml bag. And Dr. Kavitha is always advised to add 20 millimoles of KCl to 500 ml bag. Other senior colleagues advise to wait And so what's your take on this issue? I think you can guess the answer. If a child presents on DKA and they're passing urine, then it is quite safe to give potassium in reasonable doses. These children are hypokalemic. They have a total body deficit of potassium. And the longer you wait to give them potassium once you start insulin, the more hypokalemic they will become. So, it's fine to give normal saline at the beginning of resuscitation and to start controlling things. But as soon as you start insulin, their potassium is going to drop. And so my practice has always been to start potassium infusions as soon as insulin started. Now, you can't tell whether it's going to be 20 millimoles per litre or 40 millimoles per litre that you need to begin with, because it's until they started the insulin, you don't know what the total body deficit is going to be. Let's face it, an established diabetic who's just not taken their insulin for 2 or 3 days is not going to have much of a problem with their potassium. But a child who's been ill for a week before they come in is going to have a real problem. And so I think you can use your common sense here. If this is a child with a first presentation, they're going to be hypokalemic. And I would start with 40 millimoles per litre. And I would do it as soon as the insulin starts. And that means I don't then have to start worrying about giving them high concentrations of potassium. Because what is the complication of central lines in type 1 diabetes, in DKA? These children are hypercoagulable. You put a central line into them, they're going to clot. And I've seen, not through the children I've looked after myself, but I've seen children who have lost legs because of this. This is not acceptable, and it's not necessary. So, I think my view is that as soon as you start insulin, you start potassium. If it's an established diabetic, then 20 millimoles per litre. If it's a newly diagnosed, I think it's safe to start 40 millimoles per litre. And then you can watch, because the one thing that you should be checking is potassium levels every couple of hours. Is that a sufficient answer? Please share your experience about using bicarbonate correction in the management of DKA. I have no personal experience of this. I have never used bicarbonate. I know of a few deaths in children with DKA. One of those deaths was associated with being given bicarbonate. The problem with guidelines is they're written by committees. And there's that proverb that a camel is a horse designed by a committee. Because everybody has to have their say. Everybody has to have their little bit. It means that things are added to guidelines which are not evidence-based, but people have strong beliefs. And we all know that a strong belief overcomes everything else. So the international guidelines talk about potassium bicarbonate, and because people cling on to this belief, it's always remained there. The ISPAD guidelines say only use bicarbonate if there is evidence of coronary insufficiency. In other words, the heart is so compromised by the acidosis that bicarbonate will help it. I have never seen any evidence that it does, but I have seen plenty of case studies which have shown that giving bicarbonate has resulted in death shortly afterwards. That's my take. Some really great questions here, guys. So the next one is acute kidney injury in pediatric DKA and the role of CRRT. My experience is that AKI is very rare. One of the advantages of having DKA and the osmotic diuresis is it maintains renal function to a certain extent. It's only when things are really, really bad and that you see AKI. And it doesn't always present in the same way. Sometimes it's tubular necrosis. But I think in the early stages, AKI is not a problem. If you have a very sick child, then my advice would be weigh them at the first available opportunity. And then you have a baseline to see whether you are overloading them with fluid or not. I'm very interested in DKA. One of the things I invested in when I became a consultant was a weigh bed, or the opportunity to weigh. And so I used to follow up all my children with weight as I was treating their DKA. And what I found was that they all lost weight, because the continuing osmotic diuresis meant that you weren't replacing fluid as fast as they were losing it. But human physiology is amazing. We are designed for dehydration. Have any of you run a marathon? No, I'm the only idiot here then. Okay, so during a typical marathon, you will lose at least 5% of your body fluid, and you're still running at the end. 5% of body fluids in 3 hours. That's a pretty impressive weight loss, isn't it? Human beings are physiologically designed to cope with these sort of stresses. And so I think, the acute kidney injury, as I say, is very rare. But I'm getting divergent. So if you weigh the child when they come in, if they're really sick, you give them the fluids, because to start with, they are going to be fluid depleted. If you're not sure about their urinary output, because one of the ways in which you stop children from dying in DKA is you are fastidious about observation. You observe everything that goes in. You observe everything that comes out. And by monitoring them really carefully, you are on top of any problems that arise. So if you think, I don't like their urinary output, this is a problem, then what you do is you weigh them. And if their weight is going up, then you can reduce the fluid intake. And then you can start monitoring for AKI. That's my answer to that. I don't know what you would say. And it takes time. It's not going to happen in 4 or 6 hours, especially if you're monitoring them. So you've got plenty of time. And if as I say, you can change things. Okay. Please share your thoughts on insulin delivery, flushing of the IV line and tube, and the rationale. I think I know what this one's about. So if you have a small child and you've got your syringe pump set up to deliver insulin, if you do not ensure that the pump is delivering insulin at the end so that you can see the insulin dropping out of it, and maybe syringe pump drivers are a bit more sophisticated, but I've known it to take half an hour for a syringe pump that somebody thought was ready to deliver anything at the end of it, because they hadn't taken up the slack, the syringe wasn't being driven properly. And so if you're trying to stop somebody's ketone production by giving them insulin, and you haven't prepared your syringe pump properly so that you know it is delivering insulin before you attach it to the child, you may be thinking in an hour or two's time, why are they not getting better? Well, they're not getting better because you haven't given them insulin. So this is why it's attention to detail. That's what really matters when you're dealing with a child with DKA. It's attention to detail. And that's one of the little details that matters. Do you advise to connect both fluids and insulin infusion to the same cannula or different cannula? This is another interesting question, because again, in the ISPAD guidelines, they talk about, in one section, about not infusing insulin, but that's through a central line. And that's a very different thing. Okay, so again, if you give insulin in a different line to the IV fluids, so when you have IV line tissues, how long does it take before you notice that usually? It depends on how quickly it's going through, but it can take half an hour, an hour. So if your dextrose infusion isn't running, but your insulin infusion is, what could happen in that hour? Profound hypoglycemia. The other thing is, how long do you think it will take for a line running, let's say, 0.5 ml an hour? How long will you notice it before that's tissued? Hours. So by having the insulin in a separate line, you are introducing hazard. If you join the two together, then first of all, you're not giving insulin without dextrose. Secondly, you will know much quicker if the line is tissued, and then you can replace it. So I have always piggybacked the insulin onto the IV line. And yeah, it's much safer to do it that way. I think people worry that there may be a problem with backflow or the pressure of the insulin, and might not be overcome the pressure that's going through the IV line. But if you think about it, syringe drivers are designed to give fluids at arterial pressures. And the other thing to remember is that a sick child with DKA has got a negative CVP. There's going to be no pressure coming back from the line. And the third thing, and we have a physicist here who can confirm this, is the Venturi effect. If you have your insulin coming through a side line, the Venturi effect of the fluid going through will help to draw the insulin in. Is that correct? So I think on grounds of safety, always combine the two lines. And it does work. Any questions from so far? And there are no silly questions at all. Okay, these are rapid fire ones. Some of them are more rapid than others. Is a bolus mandatory for every child who presents a DKA? No. If the child's just been vomiting if it's an established diabetic for starters, who's just not been given their insulin, or they've had a tummy bug, or whatever, they're not going to be that dehydrated. One of the commonest causes of DKA now in the UK is insulin pump failure. Not the failure of the pump, but the cannula, or something's gone wrong, and so the child's not getting insulin delivered, and within 8 hours of failure of delivery with an insulin pump, that child will have ketones of 3+ and be vomiting. So the commonest cause of DKA in the UK now is insulin pump failure. And these children come in with normal blood sugar levels. They'll be maybe 200, 250, because they've not been eating overnight. Do they need to have a fluid bolus? They are not dehydrated at all. Why is their skin shut down? Why are they so pale? Why is their capillary refill so poor? Acidosis. If you are acidotic, your capillary refill is very poor. These children are not dehydrated. They don't need fluid. They need the ketones to stop. So the answer is, it is not mandatory. However, if you've got a new presentation of a child, they're almost certainly going to be dehydrated, and it will not cause them harm to be given 10 or 20 mils per kilo as a dose. So first presentation, I would say that's a good idea. Established diabetics? Not really. And that's the other thing about, it's not written here, but this idea about the delay between giving insulin and fluids. So you should wait an hour between the starting of fluids before you give insulin. Do you know where that came from? So it came from a study, a prospective study carried out in the UK, where every child in the UK was notified to a central register, and their notes were examined to see what the outcomes were. And what they showed was that cerebral edema was seen more often in those children who were given insulin at the time of diagnosis. And that the longer the delay, up to about an hour, the less likely they were. Now, that's an observation. That's not causation, that's observation. But it was a very powerful observation, and we couldn't ignore it. So that's why we delay an hour. It may be mythical, but if you see something, you shouldn't ignore it, should you? Okay, so that's the so that's why there's the so-called delay. So if you have an established diabetic, somebody who's just pumps failed, or who's just not bothered giving themselves insulin for a couple of days, they neither need a fluid bolus, and you don't need to wait to give them insulin. So I manage most of my cases of DKA now with the parents over the telephone. So the parent will phone me and say, my child's vomiting. I say, have you checked their ketones? Oh, yes, they're 6. Is your child breathing heavy? No. Right. That tells me that their pH is more than 7.1. Right. Give them a dose of insulin. And do you know how much insulin to give? Half a unit per year of age. It's always enough to stop ketone production, and never so much that it will cause hypoglycemia. And so I say, how old is your child? 6. Give them 3 units of insulin now, instantly. Call me back in an hour. And I don't admit these kids because within an hour they've stopped vomiting, they're drinking fluids, and then they can start to normalize their blood sugars again. Saves an awful lot of money, expense, and upset. So established DKA in an established child can be managed differently. You don't need these guidelines in the same way. But these guidelines are safe for somebody with stuff in that sense. Urine ketones versus blood ketones. So blood ketones are very new. And the beauty of blood ketones is it tells you about the active metabolism of ketones. So it tells you whether ketones are being produced or not, because it's beta-oxybutyrate. Urinary ketones are acetone. It's a byproduct of metabolism. And the problem with urinary ketones is its history. Blood ketones is what's happening now. So I would say if you can use blood ketones, do so, especially at the time, initially. I know some people advocate, serial blood ketone measurement, but to be honest, if the child's getting better, why? You can see if a child's getting better. A test doesn't help you at all in that sense. So I would say blood ketones are the best thing to do, and certainly at the beginning. But if you have no blood ketone strips, then urine ketones are acceptable to make the diagnosis of DKA, but not for the monitoring. Regular insulins versus analogs and biosimilars. Mixed insulins versus analogs. Okay, this is not a short answer. There's an expression in the UK, I don't know if you've heard it, but the best thing since sliced bread or bull dung. And what you have to remember for the companies that make insulin is that once the patent has gone on their product, they no longer make profits. As soon as somebody else can manufacture the insulin, their profit margins shrink. So they have devised a technique of introducing a new insulin every 10 years when the patent runs out, and then telling you that this is so much better than the last insulin we had. You must use this one. So whilst there are some advantages from the newer insulins, most of the advantages are marketing buildup. I know because I've used these old insulins. That's all we had. And my kids used to do very well, thank you, on those old insulins. And they were a lot cheaper. And in fact, we are now running into problems with the newer insulins. So, for example, with Degludec, because of its slow absorption profile and very prolonged half-life, here are 2 problems that exist. One, if you are a sportsman, it's the worst insulin possible. Because if you want to be very active one day, especially for young adults who may go and play soccer for one day and then have 2 days when they're not playing soccer, and then play soccer for another day, what happens is that they run around for 2 hours, that night they go hypoglycemic, they're hypoglycemic the next day, and then they start to get better. Now, if you want to reduce the dose of Degludec, you have to reduce it by at least 1/3. So basically, if I had a young adult on Degludec, and they're, say, on 40 units of Degludec a day, I'd say, right, you're going to play soccer, so tonight you only give yourself 30 units, and then give the next 10 units the following day, in the morning, and then give yourself your usual 40 that night. It's so complicated. It's so much easier when you're using something like Largine or Levemir or Detamir, when you can actually reduce the dose that night, and it stops them from going hypoglycemic, and you don't have to mess around too much. So all I'd say is that, that's one problem. The second problem is we're finding in young children. So if you look at the circadian rhythm of blood sugars and insulin resistance in young children, it's very different than what it is in adults and teenagers. They tend to be insulin resistant in the evening. And one of the things we've noticed with the children on Degludec, the little ones under the age of 10, is that they go to bed at 7 or 8 o'clock, and at 9, 10, 11 o'clock, they're hypoglycemic. They haven't eaten anything. They're not doing anything. They're hypoglycemic. It's because Degludec has the wrong absorption profile. So we're now reverting back to the standard insulins because it manages them much better. Here's another one. So Fiasp, I bet you they're marketing this saying you can give it just before you eat. Bullshit. Sorry. Bullda. How is insulin absorbed after you give it by injection? It diffuses through the capillary network and gets absorbed in the bloodstream, and it diffuses into the lymphatic network. Remember lymphatics? Because you can't see lymph tissue, because you can't see lymphatic vessels, everybody forgets it exists. But a significant amount of insulin is absorbed through the lymphatics and then gets put in that way. So, how can adding vitamin B6 to an insulin make it absorb so much faster that you can give it straight away? And the answer is you can't. The most rapid-acting insulin of all still has to be absorbed through the capillaries and through the lymphatics. It's going to take 15 minutes to 30 minutes before you have an effective dose, even with Fiasp. So all you're doing with children by giving the message, you can give your injection and then eat, is giving them hypoglycemia. It is immoral to be giving that message. What it means is that you can wait for just 20 minutes instead of 30 minutes for your dose to be absorbed. Because remember, if you're on a high starchy carbohydrate diet, glucose is being absorbed as you chew. And so blood sugars are starting to rise as soon as you start eating. So if you want to avoid the post-meal hypoglycemia, you have to give your insulin before. And it doesn't matter what insulin it is. All that matters is maybe a difference of 5 or 10 minutes. But they should all be given before. So for India, I would say that the most appropriate insulin is the one that people can afford. And that Act Rapid and Isofane or Insutar are absolutely fine. And they work just as well as anybody else's insulins. And if they're cheaper, they're the ones you should use, perhaps. Have I been ranting? And a similar question, insulin delivery via insulin syringes or versus pens or pumps. Okay, so it depends on the economic environment of where you're living. The best way of delivering insulin at this moment in time is through an insulin pump linked to CGM and with a good algorithm. And there are now more and more of these becoming available. And it is magical. Because what it means is every night the child's blood sugars normalize. And they wake up in the morning with a blood sugar in target range. So a third of their lives they have normal blood sugars. And you don't have to do anything at all. It's wonderful. But you have to be able to afford that technology. Okay, so moving to the real world for you. Syringes or pens. So when you dial up a half unit of insulin and you inject a half unit of insulin to a child, say a little child, how much do they actually get? Sorry? Yes. They get less than half sometimes of the insulin that you're asking them to be delivered. Because one of the things I learned when I was as a research scientist was you need to really understand every element of what you're doing. Not just the insulin that you're delivering, but the mechanism by which you're delivering it. I mean, again, we talk about, I'll go sideways again. When you give an injection of insulin, in India it probably doesn't matter so much where you give it. But in the UK it matters a lot because of the environment. It's cold out there in England. And if you give insulin into your leg and you're a girl wearing a short skirt, that insulin is going to take 3 times as long to be absorbed as if you give it in your abdomen. And twice as long as if you give it in your arm. So where you give it, and the time of day you give it, and the temperature outside, all makes a difference to how the insulin is absorbed and how long it lasts for. So all these variables kind of overwhelm these other things. And then when you look at insulin pens, they look so precise. I mean, you can dial up 0.5 of a unit. But the actual reality of what you're delivering is not quite the same. They're not as precise as they look at. When you actually draw it up yourself in a syringe, if you've got good eyesight, well, again, there's going to be an element of variability. But when you think about the variability in physiology of the preparation you're giving it to, here's a child who may be running around or sitting down, who may be tired or may not be tired, who may have eaten all their food or may not have eaten all their food, who may have had an ex. I mean, when you think of all the other stuff that's going on, pen, syringe, again, whatever's cheapest, whatever people feel most comfortable with, whatever works for them is what I would say. Glucometers versus CGMs. Again, this is a resource thing. There's no argument in the sense that what continuous glucose monitoring gives you is a history. It gives you a story. It tells you the story of your blood sugars, what's been happening. It tells you what's happened after your meal and what's happened overnight. But what does CGM measure? Interstitial glucose levels. Okay, what factors affect interstitial glucose levels? One of the things I've always done is I've always used the devices that I give my patients. Because how do you know what it's, how can you really give advice about something unless you use it yourself? I used to let children practice on me before their first injection. Because that way you know what it feels like to have an injection. And I know that most of the time it doesn't hurt, but sometimes it really does hurt. So anyway, coming back to the CGM, I've used all these CGMs. In fact, I think I was one of the first people in the UK to actually have one of the Medtronic original devices. And so what I've learned is how wrong they can be. So you put one on your abdomen, you lie on your tummy. The alarm will go off in the middle of the night saying you're hypoglycemic. No, I'm not. I've just been lying on it. And the compression has stopped the tissue fluid from glucose getting the tissue fluid. I have a hot shower. My blood sugar shoots up. No, it doesn't. The interstitial glucose has gone up because of increased capillary perfusion. I've gone out for a long run and it's really cold outside. I'm going hypoglycemic. No, I'm not. It's just it's so cold that my peripheral circulation is shut down. So what you have to be really careful about when you're doing CGM is to remember this is not blood glucose. This is tissue glucose that is pretty close to blood glucose, but is not exactly the same, and you have to be aware of what could be making it wrong. But overall, it's wonderful because it teaches you about your response to the environment and insulin and food. And it means that you get warned. If you truly are going hypoglycemic, it gives you fair warning, or if you're going hyperglycemic. So as a rough guide, it's fabulous. But for precision, you've got to be careful. I'm conscious that I go off in tangents. I don't know, does that answer that question? Okay. Would you follow giving the insulin, waiting for 15 to 20 minutes, and then asking them to eat? Yeah, absolutely. I've given that explanation already. And that's all those questions. So if you have any more, or if I finish my time, then yes. Okay, right, so I think this dates back to the early days of treating DKA and cerebral edema. Actually, a quick word about cerebral edema. I'm a living fossil. I've been around a long time. I have only once personally seen a case of DKA, of cerebral edema. And this was in a young adolescent who had been admitted through the emergency department, and the adult physicians had given her 4 liters of saline in 1 hour. And then they thought, she's a child, let's send her off to the peds. And she arrived in the ward complaining of a headache and feeling a bit drowsy. And we just immediately stopped the IV fluids or reduced them. And while we were waiting to think about doing a CT scan and mannitol, she started to improve. And that's the only case that I personally see myself. Another case that was admitted under a colleague of mine was a child who was so ill when she presented, she had cerebral edema at the time of admission. she developed a cerebral vascular incident and developed a mid-brain lesion, but she recovered in the end. And the only other one was a child who developed cerebral edema post-treatment, who ended up with cerebral palsy, who was very badly damaged. That's it. So these guidelines talk about cerebral edema. It makes you terrified of it. Wow, it's going to happen. No, it's not going to happen. However, if a child on your watch starts to show signs, then you know what to do. But I'm still waiting. Coming back to your thing about subtraction of fluids. A child who's had a long history, first presentation of diabetes, they're so dehydrated anyway. And they've got all these shifts in body fluids. You know, we're talking a real mess here. I think up to 20 mils per kilo. That's just kind of the wind going by. If you're giving more fluid than that, because of the worry that it might be associated with cerebral edema, then people say subtract. And that's why they say give the fluids over 48 hours. It works. And we know from the studies of using high and low fluid volumes that it doesn't seem to make much difference. I think avoid giving huge amounts of fluid because that's probably not a good idea. But following the guidelines here, I think is not a problem at all. And certainly 20 mils per kilo, I would not be at all bothered about. Does that answer your question? Okay, so again, if the child's still ill at 48 hours, something's not right. Something's gone wrong. So is it your insulin infusion's not right, or is there something else happening? Is it septic? Or AKI? The vast majority of children, once you stop ketone production, and the body naturally clears ketones, they will start to improve. And once you get the blood sugars down, so they no longer have an osmotic diuresis, then they're going to be safe. And what you're doing with the rest of it is avoiding overtreatment. That's what the guidelines do. They stop you overtreating somebody, because as soon as they're able to eat and drink, or start drinking themselves, the best management of human fluid is the human brain. So the child is the best monitor of whether they're thirsty or not. So, can you answer me a question? Why do people give IV fluids at standard rate overnight? How many of you drink when you're asleep? So why do you give fluids at daytime rates at night? Doesn't that make the children need to go to the toilet more often? Does it do any benefit at all? Sorry, I could never understand this. The infusion sets should be timed according to the circadian rhythm. So once a child goes to sleep, the fluid rate should end. I am really deviating now. Sorry. No, please. It's the best way. Yeah. Okay. So I've talked about the farm. You may have missed it. I talk about what was the appropriate dose of insulin to give. And I was saying how even 0.05 units per kilogram is a pharmacological dose. It's double the normal dose of insulin that children are on. However, the exception to this is children with insulin resistance. So if you have an obese child, especially if they have acanthosis nigricans, you know they are insulin resistant. For those ones, I'd give 0.1 unit an hour, because they are much more likely to not respond even to this 0.05 units per kilo per hour. It'll probably stop ketosis, but it won't really correct their blood sugars, and it'll take them longer to get better. In fact, I had an example not so long ago. I had the ward call me to say that this child, who I know is insulin resistant, because she's on metformin and she's on about 2 units per kilogram of insulin a day, huge doses, and she'd forgotten to take her insulin, as they do. And so she had been admitted, and they phoned because she wasn't getting better. And of course, they'd followed the guideline, 0.05 units per kilo. So we just doubled it, and she got better. But that's a very good question, and they are the exception. Established diabetics who are known to have insulin resistance, or an obese child who looks as if they may have insulin resistance, they will need to do the dose space. It will be, which is why both ISPAD and BSPED guidelines say up to 80 kilos. Once you take the calculation of 80 kilos, they don't need any more fluid than that. The fluids that were given, the standard formula, I'm not going to deviate, because the history of what the total daily requirements of fluid in human beings are in terms of the research is really interesting. If you want to really sort of understand the mythology of a lot of what we do, go back and read the original papers about how fluid requirements were calculated. It's an eye-opener. So 80 kilograms is more than enough fluid. Okay, so you have to remember that when I started off, that's how all insulin was given. So and in fact, you could use all combinations of insulin. So we used to use the analogs, ActRapid, or animal insulins, and isoflave. And you mix them all in the same syringe, because if you can work out the profile over the day, and it actually could cook quite nicely with breakfast, lunch, until the afternoon. So mixing insulins is a very effective way of reducing the burden, but it's not as physiological, and if it's done properly, it's not as good as a basal bolus regime. But one of the problems, especially with adolescents, of giving basal bolus regimes is it gives them more opportunities to forget. And if you're at school with your peer group and it's lunchtime and you're all chatting, you do not want to go off to the toilet to give insulin. You want to stay with your friends. So I've always done a lot of audits. I didn't want to give a lecture, but I've got some wonderful slides of the outcomes, the metabolic outcomes of children on twice daily mixtures, on basal bolus regimes, and insulin pumps. And actually, for adolescents, the twice daily mixed insulins had better outcomes than basal bolus, because they didn't forget. They only had to remember twice a day. So the outcomes for adolescents were better. However, what you cannot do is you cannot convert somebody from a basal bolus regime to twice daily. It doesn't work. They just can't get their heads around it. So if you've always been on twice daily mixed insulins, then you can do really well. So again, the answer is yes. And I've done this using mixtures of giving mixed insulin and sort of short-acting insulin as well. I mean, how else are you going to correct in the middle of the day? I mean, you obviously got problems because you've got a lot of insulin around and you're more likely to have hypoglycemia. But yeah, one of the things I learned, and if you really listen to parents and children, is that what matters is what works. Just because somebody's thought of a really weird way of looking after their diabetes, if it works for them, well, then that's wonderful. Learn from it and think, oh, okay, that's interesting. How can I apply this with somebody else? Your question about insulin at school. This was a huge deal in the UK. And 10, 15 years ago, schools refused to take children in on basal bolus. The parents had to go in to give their injections. This is unacceptable. So a massive program of education of schools took place. Now it is unacceptable for a school not to allow it. And in primary schools in the UK now, it is really good. The teachers, the secretaries, the dinner ladies, they're all taught, and there are multiple people who will give the child the injection or supervise the injection. So primary schools are not a problem in the UK. It is a question of good education for the staff, them feeling confident that they're not going to kill the child. Because that's their worry. They think, oh, I'm going to give an injection and kill this child. And what do parents worry about when their child goes to school? My child will die at school. I mean, these are real fears. And good education and support helps to overcome those fears. Secondary schools are a different thing. That's very hard because they will not supervise children. And children refuse to be supervised as well. and that's much more of a challenge. But I think it's unacceptable. A school should be a place where a child is safe and looked after. Are there any pulmonologists here? Respiratory physicians? Because I was going to ask her, would it be acceptable for a child with asthma not to be able to use their inhaler in school? Or any child who's taking medical treatment that needs to be managed at school, is it acceptable for the school to say no? No. So why should it, just because it involves a needle? Yes, there's that worry as well, but in the UK now we have to use safety needles in school. So once you give an injection, the needle can no longer be used. They're expensive, and I guess maybe not super here, but no, it's not acceptable. It really is not acceptable. But it takes time and patience and understanding. You have to see it from the teacher's point of view as well. They're terrified, and so you have to support them. Does that answer your question? In the UK, we have a thing known as the Disability Discrimination Act. Any school that refused to take a child in because of a medical condition could be sued by the parents. And the same in America. No school in America would refuse this because they'd be sued. So I don't know whether that is an avenue that could be explored here as well. Could you sue a school for not providing your child with medical treatment?
So shall we launch the app? The key thing today, I want you all to see how it works. Is that okay? And he's here, so you can ask the questions as we go along.
Can I just have a quick word?
Yes.
I was so excited when Kavitha said, can I support them when they're developing this app? For several reasons. One, because children die of DKA, and no child should die of DKA. It's a very manageable condition. What matters is ignorance and lack of support. And what this app offers is the opportunity for people who don't have that knowledge or the support from a senior at night to be able to follow through a program which allows you to safely manage a child with diabetes. If you follow this app, you will not kill a child. And what really excited me was the fact that this was an app designed by Indian doctors for the use of Indian children. So in other words, it's not from, it's not given to you from outside. And I just thought this was a wonderful thing. And these three people, Kavitha, Dr. Satish, they have done this. It's a wonderful thing, and I think we should applaud them before anything else.
So it is our national effort as someone who has been developing in India. So the support from all of you would be very useful.
Lina, come here. So, Dr. Wilson, come. Lina, come.
In the UK, it's only 100 units. It's the only incidence available in the UK is 100 units from there now. So this is, the fact that you've got a choice here makes it really important. because it matches what you have available.
Sir,
Yeah.
press the submit button. So after submitting, the second screen appears. Here you have to enter the pH, and you have to do VG and enter the pH. Serum ketone, which is approximately, if you enter, it's 5. Then you have to enter blood sugar. You have to select the unit of blood sugar. It can be selected as milligram per deciliter or millimole per liter.
If you put in the blood sugar, which is 200, it says consider the diagnosis.
If we don't have a blood ketone,
Yeah, so we'll answer that question. But now ketones are available, and we'll also tell you the source from where you will get it. So, let's see now. Severe decay. Yeah.
So here we get the diagnosis of severe decay. We have to press next. Now there comes the role of ABC. Like how's the GCS of the patient? This is a GCS calculator. You can select. This is GCS is calculated as per the age. As we have entered that 20 months of age, the GCS is selected for 0 to 2 year of age. Here we can select and we can have a GCS score downstairs. It is the GCS is 13.
and that's one of the easiest things Vivek could do, because none of us can remember the GCS score, I suppose, and we spent our life on it to make it simple for you all. And he has put the scores for, again, independent age group. There is a modified GCS score where the child is not going to respond verbally. So we put in for the younger children, the cooing, the response, everything is put in. So all you have to do is look at your child, put it on, and then that gives you a GCS score.
Midnight 2 o'clock. You have this score available.
Let's say ABC. If the patient airway is maintainable or not, we have to enter. If it is not maintainable, we can select no. If there is shock or no, if there is shock, you can select yes. Then if there is a persistent vomiting, there is a role of putting in an RT line. That's why we have to select if there is persistent vomiting or not. Suppose here the persistent vomiting is there, and if patient having fever, then we submit this reading. We will get the primary management of the patient, like attach monitor, establish stool IV line, collect sample for live evaluation. Here, as there was a shock, so you have to give the bolus, which is 10 ml per kg. It has to be given over 15 minutes.
So that comes from your weight. So all the calculations are as per your weight.
Okay. Then, as there was a shock, and there was, you can see over here, there was shock was present. Hence, consider intubation ventilation was suggested if required, and consider. It is not. We are not saying that you should be intubated. You have to evaluate, and we can consider intubation. The ice tube insertion has to be done, as there was a persistent vomiting. There's chances of aspiration is there. If there's a high glucose content in the abdomen, that has to be removed so that glucose level should stabilize. We have to start antibiotic, as there is fever is there. After that, you have to see if there is a urine output or not. If there is no urine output, you have to see if there is a serum potassium is available or not. Suppose a patient has just came up, we doesn't have a serum potassium, we can select no. We submit it. Then, as there is no urine output, you have to give just normal saline dose as an infusion. If there is a urine output and we submit it, we can add potassium. Just if there is urine output or not, no urine output, we can the fluid changes.
Yes, that's the bit a lot of you are confused, because each one of us says something different to you all, and that is going to guide you. And that's what Dr. Lamb was very particular that we need to put that on. Urine fast, not fast. Then you should be confidently putting the potassium in, because again you're going to review your electrolytes anyhow. So I think that will answer your question. And the next line, if you all can see, we said you need to flush the tube with 5 to 10 ml of your insulin infusions when you set up your syringe driver, to make sure that, so what it is saying is you need to look for the insulin drop at the end of your tubing, which you're going to connect to the child.
So after that, this is a slide for monitoring. How regularly we have to monitor the patient. Every 1 hour you have to monitor blood sugar, signs of cerebral edema, fluid balance. Every 2 hours you have to monitor laboratory blood glucose, venous blood gas, and electrolyte. After first reading, you can monitor every 4 hours. Now this is the theory part. steady in the sense, once we have started, we have given a bolus, then we have started the infusion. Now how we are going to manage the patient afterward? This is IVF titration. We have to manage fluid according to blood sugar. So if blood sugar is more than 250, we have to continue with normal saline. If blood sugar is between 110 to 250, we have to shift to 5% dextrose. This is a general guide. Later on, management of after giving the bolus and starting an infusion, how we will be going to titrate the fluid.
Maybe this is bit. I get phone calls. How many ever times I've told them. So now this you will not ask anyone when to switch, because if you don't put your dextrose in, that's when you're going to get the hypoglycemia, which is what Dr. Lamb was saying. With pediatric diabetic ketoacidosis, if the mortality is going to be associated either secondary to hypokalemia or secondary to your hypoglycemia, not really of cerebral edema. So these are the things you need to be cautious when the blood sugars are dropping, that you need to switch to a dextrose containing fluid, but not switching off your insulin, because the insulin is needed to switch off your ketones, but to maintain the blood sugars, you need dextrose containing fluid to be added while you're treating the child still.
Same here, same for the potassium titration. How to change the fluid according to potassium, serum potassium level. If potassium is less than 3, we can give 20 millimole per 500 ml solution. There is a guideline that if you have to increase the potassium level over 40 millimole per liter, you have to put a center line. We have to give the potassium through center line. For 3 to 5.5, we have to convey the same fluid. For more than 5.5 millimole per liter, if there is no urine output, you have to avoid potassium in the fluid.
This is if at all we was talking about acute kidney injury that can happen while you're sort of titrating all your things. And if you see that halfway through your management, if your child is not passing urine, you need to be aware of it, and this will prompt you, if you go and look at it, what needs to be done.
During there is a signs of cerebral edema. How are we going to identify? There are signs of cerebral edema given over here, like headache, irritability, decreased heart rate, increased blood pressure. And if there is a sign of cerebral edema, you have to decrease the IV fluid. First, you have to give 3% NaCl. Those has been calculated as per the weight of the patient that we have entered in the initial fluid. So 75 ml of 3% NaCl over 15 minutes we have to give, or we can give 20% mannitol. We have to restrict the IV fluid to half of the infusion we have started already. So it has been decreased to 41.5 ml per hour. If you see that because 83 ml per hour actual fluid was going on, in cerebral edema we have to decrease it to half the rate.
Coming from your earlier weight, adjusted to that, adjusted to the age.
You don't even have to use anything. If you've inputted your correct values at the beginning, it's going to help you through, depending on, we've sort of put in what were the possible problems we face from our experience. And so those are the things that are coming through. And so if anything comes, you need to go and click on that button that will guide you through. So with regards to the weaning protocol, we were just trying to see, consider stopping intravenous insulin therapy, and I think my trainees will agree. Immediately this happens, they're all going to ring me. How much ever I've told them, this is what you need to do. It's been 4 years since my return to India and I still get the phone call. I'm not moaning at it. I just wanted my trainees to be independent as well after 4 years of training. So now at least they will look at this app because that will tell them what they have to do. So stopping intravenous insulin therapy and shifting to subcutaneous insulin therapy. If your pH is normalizing, still there can be mild acidosis, but as long as your pH has come to 3 and your ketones are less than 1. If the child with DK is alert and tolerates oral fluids without nausea or vomiting, acidosis is resolved and blood ketones fall below 1 millimole per liter. You can check that and see. Start subcutaneous insulin at least 30 minutes before stopping your intravenous insulin. Do you know why? Yes. So you need some insulin to be in the body. What Dr. Lamb was saying, when you give subcut, it's going to take some time to get absorbed to your capillaries as well as your lymphatic system. So you need something on board before you're going to switch off your IV insulin. Subcutaneous insulin should be started according to the local protocols for the child and with newly diagnosed diabetes, or if the child is known to be living with diabetes, he, she, or should be started back into their original insulin regimen at an appropriate time. Please discuss this with your pediatric diabetologist. Stop intravenous fluids even if the child appears mildly dehydrated, as he, she will be able to correct this with good oral intake. I think my mentor has reiterated so much time. You don't need to wait until the complete correction of your acidosis. Because if you allow the child to eat and drink and give the subcut insulin, they're going to correct themselves, which is the best way of managing rather than us trying to calculate and give fluids and the insulin via the drips.
So if the patient is non-responder, we can see why the therapy is not responding. There are the causes of persistent acidosis, like insufficient fluid we are giving. Then we have calculated insufficient, proper calculation is not there fluid. Insufficient insulin we are giving, or inadequate restriction fluid we have given. Fluid or insulin is calculation error. As I said, when we calculate the insulin and we have not flushed the line, there may be chances that for half an hour to 1 hour there was no insulin infusion was going on. So you have to check the blocked or leaked line, excessive urine loss, lactic acidosis or sepsis is there, then there is a chances of that the patient will not respond. Hypochloremic acidosis or salicylate or other drug which may cause acidosis in acidic pH.
And I think most of you will agree there will be some cases with persistent acidosis despite you thinking we've corrected, we've done everything. And that's the time you need to look at all these things. And when somebody calls me that saying that our child has not corrected, the first thing I go and look at what insulin preparation has been done. So I start my protocol from the beginning again. Independently, I would not look at what the calculations were done, because if you look at, you get influenced by the mistakes. So you do your calculation independently, and this is the learning I've learned from my guru of Lam. Because if things would have gone in the middle of the night when we used to woke him up, in the sense that I woke him up, he would start from the first block. How much of insulin did you mix? How much rate it is going through? What is the weight of the child? And he will be on the other side of the phone. He'll calculate himself and he'll ask me, are you giving this amount of fluids? And that's how I know, because he will not ask what I was giving, but he will tell me what his calculation said. So that's what we are trying to say, that, you have to calculate all your doses of both the fluids, the insulin, and sometimes it can be just a prescription error as well, because 0.05, somebody will write 0.005 or the other way around. So all of that, this is only if your persistent acidosis is there and your children are not correcting as you've expected them to, then you need to look at all of this. And as Vivek rightly said, sometimes these children will present with sepsis, and that's where that sepsis might have tripped them into DKA. They are known to become diabetes, I would say, but just some infection has tripped them over and they declared being diabetics. So in that case, might be that sepsis has initiated the DKA, but if you don't correct the underlying sepsis with your antibiotics and the fluids and correct the lactic acidosis, these children are not going to get better, are they? So that's what he was trying to say, because again we had a lot of discussion. Vivek was saying we have to put a question about antibiotics to be given or not, and then I'm saying why antibiotics in DKA, and then he's saying I have seen children coming with sepsis, and if you have not covered them with antibiotics in the first 1 hour, then they're not going to get better. And I could understand his logic, and that's when we put the antibiotics question into it. Fever. If there is fever, you better cover the child, because you don't know what you're dealing with. So it's better that they're covered with antibiotics. And the other thing he was also putting was his persistent vomiting. Sometimes they'll be continuously vomiting. And he wanted to put that question again there, because he wanted to say or guide the trainee who was looking in the middle of the night, if there's a continuous vomiting, you people have to think about aspiration pneumonia. That's another cause of death, because their conscious level is not good. On top of it, they're vomiting. There is every possible chance to aspirate. So that's where we got those 2 questions in. So anion gap is Dr. Satish's baby, I was told, because you would all have known him before me. And so anion gap is his cup of tea. So ABJ app goes with his name globally. So yeah.
So if you say 160 is sodium, chloride 96, and bicarbonate say 12, your anion gap is 52. So don't put your brain where nature can help. So simple. You can have corrected sodium. So if sodium is 160 and blood sugar is 300, the corrected sodium is 153. So this way, and then there are pearls. These are certain rare situations in DKA, and we have collected a lot of these by our James. William and Kavitha have collected those pearls. Why I wanted you to be on this side is, I want you to collect these and email us to them. So we would keep adding those pearls on your name. So we would have collection of pearls by Rainbow Children Hospital. There would be some day-to-day issues, and let's do that. Okay. So all these are here.
And it seems that's what has happened with his ABJ app, and that has become really good now because of all the issues that have come through to him. And I would really appreciate emailing us those questions. Something has not worked on it, and all 4 of us would like to look at it and get a solution.
For the ABG app, has had no difficulties for last about 8 years. There were 3 lakh plus users across the world, and it's doing very well. I'm sure this app also would, but your help would be extremely useful. So this is where we all must keep adding to the real life situations. And your name would be there as to who shared that part. Okay.
There is a section of info. If you want the theoretical part of how DKA app work or how the basic guideline, we have put it in a short, in an info part. The info button is seen over the screen. If you click it, there is a short overview of pediatric DKA as per BSPD guideline. So if you have some issues, how it is working, the app is working, or what are the guidelines for BSPD, you can go through it and have regular info through it. This is the resulting.
Yeah, and you've got the references from there, we've got it. And we've acknowledged who all herself. And one of the primary person I have to acknowledge, I have to be proud about, is my son, who is a 17-year-old. He is the grammatical person because he was born and brought up in UK, and how much he has done. And I'm having battle with these two people saying, what's wrong in that English? And then Dr. Lamb is going, Kavitha, he's right, change it. So, very thankful to Dr. Satish. He's given that acknowledgement to him on the app because he has spent so much of time on that, trying to correct all the grammar. Because that info we've not copied from anywhere. It's how we designed our algorithm and what we were doing. So it was in our own words we were trying to write the whole info sheet. So yeah, thank you. Any questions?
We're not going anywhere. We can't escape from this room. So if you don't want to ask questions,
one thing why we showed this app to you is this will tell you how an app can be made. A lot of people ask me that they want to make an app. Now this app demonstrates that if you want to make an app, you need to make an algorithm. Because we will not be able to program it if you don't give a precise algorithm. And as physicians, sometimes we are not mathematical in thinking. So what we have done is converted the algorithm into an app. So this should be your habit of thinking. It has to be yes, no, if no, these options. If you choose this, then X, Y, Z. So this is what the app would tell you. We would be very happy, and Vivek and me would be very happy in helping you in making an app. If you have a thought, please email us. This is how an app can be made, and we can do a wonderful job. Let's work together for this good cause.
Yeah, and thank you. And as I said, it's going to be a free app, and we would like you all to try it. And if there are any issues, let us know, because then we have to make it uniform across. And my colleagues in UK have been trying on the test flight mode. And Dr. Lam will now encourage, I suppose, because that is what he was trying to say just an hour, 2 hours ago, saying that I should collect my cohort where we managed before the app. And now I think most of my trainees will use the app because I'm there in the background, and if there is something that goes wrong, it's easy for them to check with me. And he wanted to collect 100 from before and 100 after, the retrospective and the current, and see that will there be decreased episodes of hypokalemias and decreased episodes of hypoglycemia? Did they all struggle at all to manage in the middle of the night? Are there any correction errors that are happening when you calculate your fluids? And he will try and do the same there and see if the people use that app. Because although we said it's a BSPD, because again, it comes to where you're trained, I suppose, but ISPAD is exactly the same, and Dr. Leena, who is part of the ISPAD advisory committee, has now just seen all of that. And I think most of them are similar, isn't it, Dr. Leena? Yeah. So I don't think there's much of a difference after the 2022 guideline. Both of them go hand in hand. And if you look at the BSPD, at the bottom it says, if anything else, please refer to the ISPAD guideline. And the ISPAD says, go and refer to the BSPD guidelines. So they are complementing each other. And I always say, teamwork, that's the last word to say. Together, we achieve better.
Yeah, and these are all the apps that are there on your smartphones. They're all free. They are designed by Indian softwares. There are about 320,000 users across the globe. And 80% are being used in Japan, US, and most of the developed world. I'm thankful to the software industry. A lot of the Indian industry have helped me in developing these apps. So please use them. But this has to be the way we must start thinking. Red and blue is my icon, because that's where oxygen is, that's where the life is. So let's do it. If you have any ideas, we'll be very happy to take it further. Thank you. You can put my name on Apple Store, on Play Store, and you'll see all the apps. There's some problem with Google presently, it will come. Okay, thank you.
Thank you. Thank you for your time.